All right, pediatric antipyresis. All right, so how many abstracts are in this section here? 34. There's a lot of them, but and let me see if I've circled any. Okay, I'm flipping. I haven't seen a circle yet. I see a circle at 18. I see a circle at 27, one at 28, one at 29, and I think that's it. All right. You got those numbers? It's okay. I'll tell you when I go through what I think is important about this. Now, just before we go into this, the abstracts, the first 8 abstracts, I think you'll enjoy reading. They have to do, and it sounds like we have a lot of. I'm a former general practitioner, and it sounds like we have a bunch of. I didn't ask you what you all did, but it sounds like we have a lot of people that are in family practice here as well, and sort of there's a crossover. So I always like an audience like that because I like to talk about things from both sides. So I did that in Canada for several years before I came down to the States, and then I took emergency medicine residency here. But anyway, when we talk about Tylenol and Pediaprofen, or shall we say acetaminophen and Ibuprofen, there's a big problem with the literature right off the bat that we have to talk about, which is that what do we use these drugs in kids for? What do we use them for? To decrease fever, and what else? And to make them more comfortable, right? Pain and discomfort. And which of those is more important? Right, because do you really care if someone's got a temperature of 103 or 102 or 101 or what? Do you really care? I mean, and tomorrow there's a really fascinating chapter that we'll have a chance to talk about tomorrow that explores some of our conceptions and misconceptions and some of the patients' in fact, the only people that probably understand this correctly are the kids themselves. In terms of what's really important here. And so there's this big problem in the literature because when it comes to measuring numbers for fever, temperature, that's obviously a lot easier to do and seems a lot more scientific than measuring someone's pain or discomfort. Now, we have tools for those things, but it's tough. It's tough to measure the pain or discomfort of a 1-year-old. It's very tough, and it can be rather subjective, and I think we all appreciate that. And so the one issue that comes up in this literature more than any other, in my mind, is that we are often using the numbers as a surrogate for what's really important. Okay, and so I just want to start off by saying that. And so, you know, let's just talk about something as basic as what's the dose of acetaminophen? What's the dose of ibuprofen? Well, the dose was determined on the basis of numerical data from antipyresis. It wasn't developed from what is the more important of the two variables. So that's really the starting point. Let's go into a couple of preliminary topics. How reliable are parents in this whole game of giving antipyretic medications and anti-pain medications? Well, in abstract 1, they point out some important things like that children's Tylenol in the minds of many of those parents was more concentrated than infants. That alone accounted for a huge amount of underdosing, okay, that misconception. In abstract 2, they saw that over half of the caregivers gave the completely wrong dose, a dose right outside of the range for both Tylenol and ibuprofen in a series of 200 kids. Abstracts 3 and abstracts 4, along with some of the subsequent ones, point out something that you all know, which was when it comes to acetaminophen, it's far, far more common to underdose than it is to overdose. And so those studies both show huge disproportion of people that are, or kids that are getting underdosed than overdose. Now, when we're talking about the commonly accepted doses that are used in most of these studies, obviously that's something that's a bit of a moving target. Generally, they're using an acetaminophen dose of 10 to 15 milligrams per kilogram and an ibuprofen dose of somewhere between 5 and 10 milligrams per kilogram. As we'll see in the subsequent papers, there's reason to question that axiom. But for the purposes of most of these studies that look at whether the parents are giving the right dose, they're going with what's on the package insert. Now, what happens? Am I standing too close to this thing? Am I getting too big? That's a little one for the audience there. Okay. Now, as we go to abstract 5, we see that only about a half of them were properly dosed. And that article brings up something else that's very important, which is a recurring theme in this literature, which is that for a quarter of the kids in this paper from Albany in Abstract 5, the reason for the visit to the emergency department was a failure of response to the antipyretic. So the kid might have been okay, but what was the reason you come here, mom or dad? And the reason is, well, because their fever hasn't gone down sufficiently. You all know this. We all live this, okay? And, a lot of that relates to what we're going to talk about tomorrow, but, is that a valid reason for them to come to the ER? And are they really understanding this correctly? Abstract 6, 68% were underdosed, and 6% only had a dose that was too much. And this is a classic paper from Philadelphia in 1987, and it brings up an important point. They say, you should always give the kids the absolute highest range of the dose for these things, because what happens, you get a dose for Johnny, and then Sammy has something, later, or Johnny has something else, I should say, 2 months later, and then he's that much bigger. Kids grow real fast, and so if you get in the habit of always using the absolute upper range that you're given, then it will help with the underdosing that tends to happen down the line. I think you'll really like abstract number 7, if you haven't heard about this one. This is what it's called the teaspoon paper from Israel. Why are we getting so many kids the wrong doses, and why are so many of them being underdosed? Well, this is a brilliant group of people who went around in Israel, and they said, show me your teaspoon. What's a teaspoon? And they found that a teaspoon, now what do you think a teaspoon is? 5 milliliters is what's passed off as a teaspoon. So they went and said, Mom, show me a teaspoon. And in an Israeli household, a teaspoon was an average of 2.95 cc's, or milliliters. Okay, so they found that teaspoon was just a little more than half of what we thought a teaspoon was, and that was their teaspoon. And so this is a big problem, and this is something that all of us need to be aware of. Is that a teaspoon is not a teaspoon, and so we really have to be more accurate about it. So that was a really interesting paper that came out. That was already in 1989, and a lot of people know about that paper. Another paper I refer to as the thermometer paper, Abstract 8, I think you'll enjoy. They took 3 thermometers with 3 different temperature readings on them, okay, old-fashioned mercury thermometers, and they gave them to moms, and they said, read these 3 thermometers and record the results. And they found that 93% of a group of suburban mothers in a relatively well-to-do area were able to read all 3 of them correctly 93% of the time. Okay, I'd like to think that I'd like to get it right 100% of the time with a thermometer. But in another cohort, the same methodology, in a less well-educated Medicaid environment, only 10% of the parents were able to give a correct reading on all 3. So that brings in another, well, I guess it argues in some ways for digital thermometers, but it also drives home the importance of the parent factors in all of this. So they need to know, they need more guidance, and they need more education about these things that we might often take for granted. And I don't think we can underemphasize that. So that's sort of the theme of abstracts 1 through 8. Now let's get down to something that I think is worth fighting about a little bit, which is which antipyretic is better, acetaminophen or ibuprofen, and that's the topic of abstracts 12 through 18. Now, all the things I said on the outset about the dosing are very, very important here, because what these papers are doing is they're generally considering antipyresis only, and they're not really looking at analgesia. And like so many studies where one drug is being compared to another, we find that everything here hinges on the doses. And so many of the papers that show superiority of one agent or another are what we call, and I think Jerry used the term today, straw man comparisons. So you all know that when Naseritide came on the market, it looked wonderful against a dose of nitroglycerin that was the equivalent of pissing in the wind, right? When they used they compared it versus these very low doses of nitroglycerin, which of course was the standard before Naseritide, and they made Naseritide look like it was wonderful. The same thing happens when they use suboptimal doses of, for example, Demerol. They use Demerol or meperidine that's way lower than its recommended dose, and compare it to, say, for example, ketorolac. And I think there's a talk on that in this course as well. And so you can always make a drug look better or worse depending on the dose. And so part and parcel, or a case in point, I should say, is abstract number 9, which makes ibuprofen look like it's more efficacious than acetaminophen. Abstract 9 uses a dose of 10 milligrams of acetaminophen, but a dose of 10 milligrams, which is at the very lowest end of the range for acetaminophen. And in each and every one of these articles, 11, 12, as we go through, you'll see that the most important variable there is the doses that are used. And so those aren't particularly helpful. When you do use a decent dose of both of these medications, they both provide a good amount of antipyresis, and there's not really much difference. If you use a huge enough if you use enough patients in the studies, you can often achieve statistical significance for one or the other, but then one has to ask, well, if you do get 0.1 degree difference with statistical significance, is that really clinically significant? And then, my answer to you is, well, of course not. I mean, I don't care whether it's 38.1 or 38.0 if the kid looks like they're more comfortable. As long as I've got a diagnosis, I know what's going on, and the kid, and I've got a plan. I don't really care about things like that. So I think that, without belaboring a lot of those, we don't have to go through all those individually. You can see that that's the important point here. Now, abstract 14 is a little bit notable because it looks at something that I think, were you guys taught that when you have a febrile seizure, that what you got to tell the parents is to religiously give the Tylenol every 4 hours so that it doesn't happen again? Were you taught that? I was taught that. Okay, I was taught a lot of things. It turns out, so that's one of the many papers, and this is just one of them. I think we look at another one later on, that shows that there was no difference in the patients that were treated in that fashion. And so it's another example of whether we're really looking at the right outcome. The proper outcomes in these studies, to me, really aren't the numbers, but whether they have recurrent seizures, that's much more clinically significant to me. And in fact, in this particular study and in some other ones, using a regular dose of Tylenol did not necessarily change that incidence of seizures. So that's an important thing, and I think it's a misconception that we have. I'll talk about it a little more when we get to another paper that looks at that specifically. Going along, I think that abstract 15 and 16 and 17 are much along the same lines. The British are so pragmatic, and you just got to love. If you get into medical literature as a significant part of your life, you'll come to love British people. Because they're just so wonderfully pragmatic and so wonderfully sensible. They never take anything for granted, and they're always skeptical about things that are expensive. Abstract 17, they did a study where they gave a combination of ibuprofen and acetaminophen. So they gave 10 milligrams of ibuprofen and 15 milligrams of acetaminophen, and they compared that to one or the other. And they found that there's a difference of, now they're using centigrade, so excuse me for this, but 1.22 degrees centigrade reduction with the combined versus 0.95 or 0.92 for the individual agents. Okay, so there's a small statistically significant difference, and they have a lovely discussion there that says, okay, we've proven that there's a small statistical difference if you use both agents together, but is it really worth it? And that doesn't even take into consideration what are the side effects of giving two drugs instead of one. And so this really speaks to the issue of clinical versus statistical significance. Okay, so I think I've beaten that one to the ground. Let's go on to something that I want you to circle Article 18 if you haven't already. That's very, very important. Is ibuprofen safe, and is ibuprofen a reasonable alternative? This paper is very important for you to have because it's this is 83,915 patients. It's a good article from Boston U. It's in JAMA. Okay, and it's the largest number of patients that have ever been put into a randomized controlled trial to compare acetaminophen to ibuprofen. The dose of acetaminophen was 12.5, and ibuprofen was either 5 or 10 milligrams per kilogram. Children received a median of 6 to 10 doses over 3 days, and what are the results? Well, what they were looking at here was safety. And so I think it probably makes sense to all of you. If you're going to look at safety, you can't study 100 kids. You've got to study thousands and thousands and thousands because these aren't the most dangerous drugs in the world. It takes a lot of doses to start to see some problems. And what are the results? Well, first thing, they had no cases of Reye's syndrome. That's interesting to me, very interesting to me. They had no cases of Reye's syndrome in all those almost 84,000 patients. They had no incidences of renal failure in this particular series. But they did have 4 cases of upper GI bleeding in the ibuprofen group, 0 in the acetaminophen group. And they had 8 cases of neutropenia in the ibuprofen group and 0 in the acetaminophen group. When you run those through the statistical test, it tells you that there's no difference, that they're the same. There's no statistical difference between the rate of those important side effects in the two groups. And then I ask you the same question. Is that the same as clinical significance? Well, to me, in order to justify the use of a medication to replace acetaminophen, okay, I want to know obviously that it's equally efficacious, and I want to know that it's equally as safe. This study shows that it's equally as safe statistically, but out of every 100,000 kids, according to this study, this would calculate to be just over 7 cases of GI bleeding. That's a serious thing. And 14 out of 100,000 would be having neutropenia. Now, if you multiply that by all of the millions and millions of doses that we take that are taken across the country, that really could be significant. So I think that I think to me, my conclusion on the basis of this is I'd like to give the drug that has 0 cases reported of these things that I'm concerned about. I don't know, have any of you seen a case of GI bleeding due to Motrin in a kid? Have you ever seen that? None of you have? I have seen one. Billy, who you've met already in this course, has seen 3 cases of this so far over several years. But it's a big deal. You know, they come in, they need to be admitted to hospital, and it's a serious matter. I would prefer to use a drug that doesn't have a record of causing that at all. Now, the subsequent papers here deal with something that wasn't seen in the JAMA study, that was seen. One is the abstract number 19 is a French study, and then there's abstract number 20 as well, is a British study. These are papers that show that there might be an association between ibuprofen and renal failure. Now, that's something that really shouldn't surprise you. You know that the NSAIDs are associated with the prostaglandin-mediated effect, right? And they're associated with decreased flow to the kidneys. And the authors of those papers report on several cases of this, and they say, look, if a kid is puking their guts out and is really dehydrated, this is not the drug to go for to exacerbate their pre-renal failure. And so they document several cases. So I will admit to you that there's some philosophical discussions to be had here about the use of statistics and about the whole concept that I'm talking about, clinical significance versus statistical significance. In fact, I was talking to one of my residents, and these guys are getting smarter and smarter, a lot smarter than we were for sure. And he said to me, well, you know what you're saying doesn't make sense, because if it's not statistically significant, what you're saying is that could have arisen by chance, that you had those incidents of side effects in the ibuprofen group. And I acknowledge that's true if you use the p-value only. But if you take a look at the confidence intervals around these things, and if you look at it, depends how you look at it, it still could be clinically significant to me that there was those side effects in the ibuprofen group. Does anyone have any comments or questions about that? It's something that usually generates a lot of discussion, because it's something that we're all doing every day. Nurses have strong opinions about it. A lot of family practitioners have strong opinions about it. So I'll continue on, and maybe at the end, if you want, we can discuss some more things. There's some other really interesting aspects to this whole acetaminophen thing, and abstracts number 21 through 26 deal with rectal administration of acetaminophen. Basically, if you look at abstract 21 from the Canadian Journal of Anesthesia, these are not ER patients, these are post-op patients. It kind of demonstrates all the problems with rectal administration. So there's some facts here that you need to know that we've delineated, and that is that PR absorption, rectal absorption, is slow, very slow. It is erratic and unpredictable, and that the doses that we're normally using of Tylenol, that we think of 10 to 15 milligrams, are woefully less than what is necessary. And so, for example, in abstract 21, they're using a dose of 45 milligrams per kilogram rectally in 15 kids, and they only reached maximum levels at 198 minutes post-administration. There was a huge variance in levels, and these levels were sustained for greater than 6 hours. So that kind of shows you a little bit about the pharmacokinetics of rectally administered Tylenol. The other studies support this ideas. In abstract 22 from Northwestern, they tried a 10 milligram rectal dose, a 20 milligram rectal dose, a 30 milligram rectal dose, and in the conclusions they say, you should probably use 40. So they couldn't get good therapeutic levels with all their treatment arms. In Scotland, in the next paper, abstract 24, they used 25 milligrams. And in abstract 25 from Children's Memorial in Chicago, they used an initial dose of 40 milligrams, and then they switched over to 20 Q6 hours because they were concerned about developing toxicity. I think that probably if you were going to have one paper that you could have as a reference on that, abstract 26 from Stony Brook. Stony Brook is, by the way, where Peter Vecellio is. We were talking about the Vecellio model and the Vecellification of emergency departments where we are able to distribute our patients around. He's one of the faculty of this course. That paper really gives a nice overview of all the concerns with rectal Tylenol. But I think, in summary, the thing to know is that the rectal route is available to you, but you shouldn't give 15 milligrams rectally, or even 20 or 25. You really should be giving in the range of 40. Then the second message is, hey, this is not a great route because it's unpredictable and you could develop toxicity. So as soon as you possibly can, you want to switch that kid on to something that's more reliable and more predictable, which is an oral dosing schedule. So I think PR acetaminophen is great if you use a proper dose, if you then wait 6 hours and then you start using oral. And maybe you're going to use antiemetics in there to facilitate an oral administration, but you don't want to continue to use rectal dosing or you might get into toxicity problems. It's just not that reliable. That's sort of the take-home on rectal Tylenol. And I know that these papers are really important because a lot of our practice is to give way less than that. I mean, I know in most of the places I've worked, we've given doses that I now realize are just ridiculous. We're homeopathic. Okay, so this is actually very practical stuff. Okay, moving on to abstract 27. This is another interesting thing, which has to do with loading dose. And it's true that you can give a loading dose of Tylenol and make a slightly better situation. In this study, this French double-blinded study, they gave a dose of they had 120 kids, and they gave 15 milligrams to one group, and the other group they gave 30 milligrams to. And then subsequently they were giving the standard doses after that. But they were able to reduce the time that it took to get their temperature under 38.5. It lasted longer, and so this is probably a reasonable strategy. So an initial loading dose of 30 milligrams per kilogram is something that's in the literature, and it's a reasonable thing to do. This paper I promised you I was going to mention and point out, abstract 28, was does the dosing strategy affect the seizure recurrence? And I'm one of these people that was telling parents with febrile seizures. I was one of the people that was saying, you know, it's got to be like clockwork. You've got to give this every 4 hours. That's the only way we're going to stop Johnny from having another seizure. And some of these papers kind of are humiliating to me as I see that it's not really panned out. In this paper, it's an Israeli paper, they had 104 kids, and they had them either in a, mom, you give it when you think it's necessary type thing, versus a religious every 4-hour administration. And in the group that had the religious administration, the regimented administration, they had 4 seizures out of the 53 of them, and in the sporadic they had 5 out of the 51 of them. There was no statistical significance anyway between those two groups. Yes?
So this is all kind of going with the assumption that we really need to get the fever down. Isn't that sort of feeding into this fever phobia?
Okay, so you mean this particular paper, or this, or all of this whole discussion? You know, there is a tone in the way that this chapter is written. This chapter is written by Dr. Clower, by Kevin Clower out in Ohio. There is a sort of a tone to this whole chapter that kind of gets a little carried away, because when you get, you know, and I think it's natural, when you get into it and analyzing this literature, which is based on numbers, you know, when you're looking at the science of it, there is a little bit, you get carried away, and there is a bit of an assumption. That's why at the very beginning of this chapter, I sort of tried to make that overall statement, and you're absolutely correct. I mean, you know, we don't want to get carried away, get carried away with the numbers. It is only a marker. Perhaps a marker, a surrogate marker of what's really important which is the kid's comfort, like I say. So you're absolutely right. And more on that as we go through, which is abstract 30 at 29 and 30. And abstract 30, if we could just jump before 29, it's an article in Pediatrics. It's not a research paper. It's a summary paper. It talks about this. It sort of gives what I think for many, many years was the prevailing philosophy on Tylenol and ibuprofen. Which is that you shouldn't really be giving these things together, and they're not necessary to give together. And basically what I was saying before, which is why advocate a more complex regimen and go with another drug when you don't have to, unless there's some evidence that it's better. It is complex when you start combining the two medications together. What we're talking about here is alternating and combination approaches. And so that was basically the going wisdom, and I agree with that wisdom. This paper that just came out, though, that's in here by Searle, who's who's done a lot of research in this area, it's also from Israel, is a really nicely designed study. It's a 464 kids. It's a randomized controlled trial that basically compares a combination therapy with either just Tylenol or ibuprofen separately. And again, just using the numbers alone, they say that there's more fever reduction, and the fever recurrence at 5 days is lower. And we mentioned that we might not care about those variables, and your point is exactly the same as mine. They said, though, that they miss one less day of daycare. But I don't know what that really means. I mean, did they miss one less day of daycare because their fever went down and their teacher said, you're not coming back in until you have, I don't know what that means. And so this is a study, though, that I think is important for you to know about because you're going to hear about it, because this is going to be all over the place. This is going to be something that people are going to be quoting left, right, and center. And so it's in the archives of pediatric and adolescent medicine. It cost a lot of money to do this study, I'm sure, and a lot of people will be quoting that, saying this is evidence for a superiority of an alternating approach. In this study, they gave 10 milligrams after an initial loading dose of either 25 of acetaminophen or 10 of ibuprofen. Every 4 hours, they gave or every 2 hours they gave a different drug. So Q4 is Tylenol and Q4 is ibuprofen, and that's the study that we're talking about. So I don't know that this is, I'm going to get your question in a second. I don't know that this isn't going to change my practice, but I want you to be aware of it. I think it's important to have in this series. It does not answer that question, which is it really necessary? Yes, sir.
They said a maximum dose of 50 milligrams per kilogram of acetaminophen daily. Is that an accepted max, or is that?
Okay, so you're talking about the max. What is an acceptable maximum dose of acetaminophen? Is what they use a little bit conservative, I think is what you're saying, right? And I think you're right. I mean, that's a little bit conservative. I mean, I don't want to go too much off topic, but it's pretty hard to kill a kid with acetaminophen, right? I mean, you got to work pretty hard to do that. Even kids that are well past all of the different standard toxic doses do well. That's the bottom line, and they did use it very conservative. But I think that in the context of institutional review boards and research committees and all these people, it was probably harder to get approval for a higher dose, and so I think that's what you're seeing there. Any other comments? The last set of articles there is just kind of like a little bit of fun, really. It talks about sponge bath, and one of the papers is from my home school from Toronto. Which is sort of a classic paper. It's basically sponging and using the drugs versus just using the drugs alone. And in that paper, they actually got lower temperatures with just using the medications alone. And that was when they even excluded the patients that were shivering because of the sponging. And so sponge bath has been looked at in a few different articles, and it's never, 31 and 32 are two examples of that, and it's never been shown to have an advantage, except there are a couple of papers, and one of them is Abstract 33 from Bangkok, Thailand, where they actually say, there's a difference between what the ambient temperature is and where you are. And if you're in the tropics, there are authors that submit that if you're in the tropics, that sponging has benefit, because there's less heat loss that can happen through the environment, and for that reason, there's reason to believe that that's a different situation. So if you want to take a take-home message from it, it appears that in temperate environments, sponge bath causes a lot of discomfort and shivering and really doesn't help you at all, but that in tropical environments, practitioners there still contend that there's a use for this, and they have some literature. It's fairly weak literature, but they have some literature to support it. The craziest article here, though, is Abstract 34. So if any of you guys are interested in going into sort of like a Stephen King sort of science, you might be interested in this. In order to simulate, in order to study this concept of sponging, they actually injected volunteers with interleukin-2. And I guess it's like a Frankenstein-like thing. And so they're very uncomfortable and they're shivering because they've just had this immunomodulatory agent injected into them. And then they studied whether this forced air-water cooling system, which really just sounds to me like some sort of a torture, made them feel good or bad, and it made them feel terrible. And so they made a conclusion that, just leave well enough alone. So it's just this bizarre paper where they torture people in San Francisco, basically, by injecting things that they ought not be injecting. Anyway, so those are the major things about pediatric antipyresis, and I think that you'll enjoy the things that we discussed. Some of the issues that you brought up about fever phobia and misinformation. There's some good papers that you'll like to carry around with you in the topic that we do tomorrow, where it has a lot of those papers. Okay, is there any other comments or questions, complaints? Yes.
Well, so we're talking about antipyresis here, which we don't care about, and what we do care about is whether the kids feel any better. And so I'm learning about Tylenol versus Motrin in that regard.
Yeah.
Sometimes it alternates because I alternate because I thought that ibuprofen worked a little bit better.
Right.
And I don't want the toxic side effects, so why not alternate?
Right.
It gives the parents something to do.
Right.
But,
Okay, so I think that it's a little bit of an oversimplification for me to say that none of these studies address visual scores and other things that look at patient comfort. Some of them do. Although it's not the major focus of most of the papers. And I can tell you that there is no evidence to suggest that, ibuprofen is a superior agent in that respect either. There is no evidence to suggest that. There is evidence to suggest that it has a slightly higher and I think clinically significant incidence of side effects. And on the balance of that literature, I can't recommend an alternating strategy or a combination strategy. But I also would not get terribly dogmatic about it because, let's not blow things out of proportion. In 83,000 patients, that study, ibuprofen wasn't associated with any deaths. It wasn't associated with anything more than 20 cases, perhaps, of side effects, which is pretty low. I just don't think it's justified.
At least for tomorrow's topic, but at what temperature do we tell the patients the parents to be concerned about the fever?
The question is, at what temperature do we tell the parents to be concerned about the fever? And no one knows the answer to that question. We'll talk about it a little bit tomorrow because I don't want to take too much more away from Jan's time. But it's a fascinating topic because it's something with which so many people speak with so much confidence and authority. But when you really get down to studying it and looking at it, it's just absolutely perplexing. We have no idea what the answer to that question is. The fact of the matter is there's a tremendous overlap between benign and fevers that are very high and fevers that are very high that are for reasons that are life-threatening and brain-threatening. And it's not necessarily determinable just on the basis of their fever alone, the number. Yeah, there's the kid and there's other factors in the diagnosis, yeah.